right, well, by now I've had the chance to meet all of you, but in case I haven't, I'm Laura McGuire. I'm happy to give this presentation to you today on the art and logic of flow-guided bypass. So this is the disclosure slide that I'm instructed to place, but I have no relevant disclosures. So when thinking about what to talk about today, there's a lot of different things that I'm passionate about. So it was kind of hard for me to pick exactly what to talk about and share with you. But ultimately, I did decide on this because it does touch upon multiple categories of things that I'm very interested in. The clinical research with bypass patency during my fellowship, and then this flow-based algorithm for treatment of multiple pathologies, but specifically ICAD, that was really ingrained in me in my training, as well as the different imaging that we used was something that we really focused on throughout my residency and my fellowship. But then also I thought that this was a nice opportunity to actually show you what the microflow probe is and how to use it, because now we do have that here at UW, and it's not just for me, it's for anybody that is interested in using it in their cases. So I thought I'd actually show you what that looks like and how it can be used and applied. So this is the outline overall for my talk, but I would be remiss if I didn't mention that my talk is very heavily influenced by my mentors, Dr. Sharpel, Dr. Alaraj, Dr. Atwal, and Dr. Hinjani, who really brought this together throughout my training. But overall, I'm going to go through a little bit of review of some of the literature. Then I'm going to go through some of the imaging that we used at University of Illinois, but then what we can do here at UW as well. Like I mentioned, I'm going to go through the microflow probe and how it can be used, and then some of the topics of my research whenever I was a fellow about why bypasses fail. So as you're familiar, there are a couple of reasons in general why you would perform a bypass. You got flow augmentation, which would really aim to restore flow to a hypoperfused brain, and that's specifically in steno-occlusive disease. And then there's flow replacement. This is where you're actually trying to replace the blood flow provided by a major artery that you have to occlude necessarily for treatment of an aneurysm or for a tumor, for instance. My presentation is mostly going to focus on flow augmentation. However, these principles do actually apply to both. So in flow augmentation, this has been studied in a few randomized clinical trials that you are most likely familiar with at this point, including the ECIC bypass study group, COS, the Japanese adult moya-moya study, and then most recently is the carotid and middle cerebral artery occlusion study. All of the studies that pertained to ICAD specifically essentially failed, despite some tweaking of the inclusion criteria for MCOS. Of these 4 studies, JAM, the Japanese adult moya-moya study, is the only one that actually showed any benefit for the bypass procedure. So that being said, indications for surgery in moya-moya disease, there's a class 2A recommendation from the AHA, ASA that supports surgical revascularization in adult patients with symptomatic moya. The Japanese adult moya-moya study that actually looked at hemorrhagic presentations, and actually there's no randomized control trial that has looked at ischemic stroke specifically. However, there's many meta-analyses and other studies that have looked at it otherwise. And so that's where this recommendation comes from. So it's pretty straightforward, clear cut for moya-moya disease. Now in ICAD, this is a little bit different story. This is something that has failed in a few different trials. However, there are limitations in each of these studies. And the most recent study, CMOS, is the one that they did acknowledge that their study, even though there might have been some trends, none of them were significant, but overall they were underpowered because they had a lower than expected event rate in both groups. So what do we do with this information? How do we actually decide who to treat, if to treat? And this is what we used at UIC. I'm curious to know what you'd use as your approach here as well, but it is a very difficult and challenging situation. So our possible approach I list here is that we have patients that have occlusive disease, so not just severe stenosis. They have impaired and or worsening hemodynamic reserve. They have failed medical management, and that they have progressive or crescendo symptoms. So those are the 4 main things that I would argue are the most important in choosing patients with ICAD, because it's essentially a Hail Mary to try and give them a bypass. So when thinking about how to evaluate hemodynamic reserve, it's important to first think about how do we image cerebral blood flow. Now, this is something that I talked about in my presentation about a year ago whenever I was interviewing here, is quantitative MRA, the NOVA system. That's what we use at UIC. It essentially combines time of flight and phase contrast sequences to allow you to select arteries and regions of interest that you want to measure blood flow on. However, there is a huge limitation to this, and it's something that we all also had issues with, is that you can't perform post hoc measurements. Basically, once you get your three-dimensional reconstruction from the time of flight, you choose what cuts you want to use for measuring the blood flow on the phase contrast when you come back in and do that. And so it's almost impossible to get blood flow in a place that you haven't already chosen whenever you go in there. On the flip side, what we have here at UW is amazing. This is 4D flow with PC Viper. So this is time-resolved phase contrast MRI. It's three-dimensional or three-directional velocity encoding, so three-directional VENC, which is important because that sets the maximum expected flow in a vessel and allows you to reduce sensitivity to noise and motion in the patient. So the spatial resolution is excellent here. And images can be acquired ultimately in all planes in a single session and processed after acquisition, which is great. So in case you find an artery that you didn't initially measure the blood flow on, you can go back and always get that image and that information. So normal blood flow ranges have been studied. I'm not going to go through this, but it's just to show that we do know what normal blood flow ranges are. And that way we can use this as a benchmark whenever we're actually evaluating these patients. But again, imaging cerebral blood flow is not enough here. We actually need to know something about their reserve. And so this is a concept that you all are probably familiar with, but ultimately normal cerebrovascular reactivity is the response to vasoactive stimuli like CO2, and it is impaired in steno-occlusive disease. So you're no longer able to give adequate blood supply to the brain. But because this process is based on regional metabolic demand, independent of systemic pressures, regional assessment of the reserve is important. The vessels distal to the stenotic artery can also become habitually dilated. This is a compensatory mechanism that we know about. So we need to add a vasodilatory challenge so that we can assess how much room there is for an artery to actually continue to respond to any issues with blood supply. And in the severe cases, you end up with steal phenomenon. So the blood is actually routed to healthy tissue in response to the vasodilatory challenge because the diseased vessel is chronically and maximally vasodilated. So this vasodilatory challenge, we use Diamox, but there are other options. Diamox tends to be the best suited for it because it's very well controlled and you can figure out the timing very easily. Plus with image acquisition, doing any kind of breath holding and carbon dioxide that's inhaled is difficult in the MRI setting. So this is what our workflow looked like. We'd get baseline flow measurements, we'd give the Diamox, wait for 10 minutes, and then repeat the flow measurements. And ultimately, what you're expecting to see is about 40% increase in vessel flow. If you have no increase or just a reduced response, then that's impaired. And then, as I mentioned, if it's the reverse, then you end up with steal phenomenon. So some of the residents might remember this slide. I did actually show this whenever I interviewed here last year. But basically, this is what the map would look like for NOVA. Currently, we don't have a map like this for the 4D flow, but I have discussed this with the neuroradiology team as well as possibly actually getting a map, something similar to this, because I think it's very easy to read. But that's a relatively normal response that you see there in response to the Diamox. The blue is after the flow after you give Diamox. It's actually a much more robust response than you'd expect. But impaired hemodynamic reserve would be seen in the right MCA. That's actually low flow to begin with, and it just doesn't improve at all. And then ultimately, you're going to see a possible steal where the flow actually decreases. So fMRI uses bold contrast. This is blood oxygenation level dependent contrast. And this visualizes hemodynamic response of increased regional neuronal activity. And this loss of response can be interpreted as a loss of hemodynamic reserve. Hypercapnia also elicits a vasodilatory response in normal cerebral cortex that results in a positive bold contrast. So Similarly, the loss of response also reflects compromised hemodynamic reserve. So we used this to actually incorporate into our protocol to image hemodynamic reserve. Now, mind you, there are actually a lot of different ways you can image hemodynamic reserve. This is really just the way that we did, and I think that it's nice, and I'll explain why in just a couple seconds. But basically, first off, this is the time of flight. You're used to seeing this, but just to orient you to this example, that's going to be on the where that arrow is. That is the occlusion of the right ICA. There's a loss of A1 bilaterally and right M1. Then the distal right MCA branches are present, so that indicates that there's some collateral flow. And then the vascular territory of the PCA there is a little bit expanded. It's cropped, so you can't see it very well on this picture, but ultimately that also indicates collateral flow. Now here is what we see after the bypass. So you see that that bypass is nicely patent. There's flow through the distal MCA branches as well. But how do we look at hemodynamic reserve? So this is what that picture looks like. So on panel A, that is a single panel of global bold. So this is where you're looking to see where there are areas of global lack of hemodynamic reserve. B is actually what you see in sequence, because if you were to scroll through all of the pictures, that's what it's going to look like. So you actually do end up with all of the slices throughout the brain. And C is the functional MRI. This is the task-based bold activation. So what we're seeing here is that the task-based paradigm is activating bold in sensor motor cortex on the left-hand side in number 2 is what it's labeled as, but not on the right side. And bilateral SMAs are out, and then not shown is the auditory cortex that's also investigated. And then also not shown is going to be the activation in the cerebellum. So that actually ensures that the person was performing the task. And then the visual cortex is not shown either, but that also shows that they are actively able to see and perform the tasks. And then just in terms of the color coding, on the right-hand side, pink and green are going to be your first and second trials. And then where the overlap is yellow. So ultimately, that's kind of what we would use as what we decided was the activation area. So this is after the bypass. So this is actually 16 months after. And so, because we would follow our patients with these imaging studies to actually see how the collateral flow will change over time. And ultimately, this patient did have repeat images later on, but I thought this was a nice example of where not only are you having an improvement on A and B of the areas of blue, so where there was previously severely impaired hemodynamic reserve that's starting to get better, but on panel C, you're also seeing that what was not lighting up before is starting to come back, which is really amazing. And so for one, you're starting to see activation of the right sensory motor area. And then in number 3, you're starting to see SMA as well. So just as a preview, I will be meeting with some of our neuroradiology team actually this week, tomorrow, to talk about what we can do for imaging hemodynamic reserve and if this is a protocol that we could potentially implement here. So now to talk about the flow probe. So I hope that this is helpful to show you how we use it and why we use it. So first off, all these different measures on the left-hand side are things that people will talk about as being a good flow or good bypass. And it's a little bit of a misnomer to say that just angiographic patency or ICG patency means that you have good flow. It's not quite that simple. You can have, it's essentially binary. There is flow, there isn't, but it doesn't tell you how good the flow is. Vessel diameter does not always indicate how good the flow is. Velocity, that's misleading sometimes because a stenotic vessel, as we know from measuring TCDs, for instance, a stenotic vessel may have increased velocity. And then pulse, people will talk about, well, they palpate the pulse of the STA, and that's misleading too, because sometimes an occluded vessel will also pulsate because it's feeling the end of that pulsation. And actually, you can argue that if the pulse has increased, that could potentially be a bad sign, because that means that they're up against a highly resistant bed, a vascular bed, or it might even be occluded. So these are the two terms that we use with the microflow probe. This is what it looks like. It's transonic. It comes in multiple different sizes. It has that flexible arm at the front, and essentially that little hook will hook around the vessel. And I do have a video to show that just to give you a sense of what that technique looks like. So the flow probe uses transit time ultrasonic technology to measure flow, which quantifies blood flow and also provides this waveform pattern that you see. So the waveform data is nice because it also gives you a sense of how good the pulsation is through the vessel, how good the velocity is and all of that. But it also gives you acoustic feedback. And so you can actually hear if it's a good pulse. You can hear if the flow is good. There's a bayoneted handle, as I showed you in that picture, and the tip sizes are variable. And I already mentioned this, that's how you use it. You just place the tip around the vessel. So cut flow, this term actually indicates essentially what it says, what an artery, when it is cut, what the flow is through it. So what is the maximum carrying capacity of blood flow through an in situ graft, such as the STA? So once you harvest the vessel and prepare it for the bypass, you use the flow probe to determine the amount of flow that can go through it if the resistance was 0. So when the STA or occipital artery is in continuity with the scalp, because of how resistant the vascular bed is in the scalp, you can have very, very low flow through those arteries. But once you actually cut the STA and measure the flow, it can get up to 60, even higher I've seen, but 60 is average. So here's the video. This is actually a clip from a much larger case, but just to show you the actual measurement of cut flow. Essentially, once you have prepared it, now this is us measuring the graft actually in continuity with the scalp, just to see what it is. And then this is where it's been cut, and he's measuring it. The flow's allowed to come through it. And we actually do put suction at the edge of the field just to keep the field clean. Then you flush it with heparinized saline and clip it off again. And eventually that vessel's going to get trimmed so that you can use it for the bypass. So what we expect for the cut flow is that it should fall within 20% of a measured recipient. This is important because anything below that 20 to 25% may result in ischemia. So if it falls beyond that 20% threshold, then you may want to consider a larger graft, interposition graft, like a radial artery or vein. And then you see in a study that we had done previously, the STA, as I mentioned, the average flow through it, the cut flow is going to be 60 versus a free flowing, like it through the vein, is going to be 80 to 100. So the cut flow index is essentially, the cut flow is the denominator, but the bypass flow, once we've connected everything, we measure it again. As you see, you can measure it really anywhere along the STA, but once it is plugged in to its recipient, you measure it again, and that's going to give you your bypass flow, because that's going to be what the vascular bed is taking. And a cut flow index of over 0.5 has been repeatedly shown in our studies to be a significant predictor of bypass patency. Caveat is that this is studied primarily in steno-occlusive disease, so it's unclear if that's true for flow replacement bypasses, for instance, but you can imagine that it should be similar. So in these two studies, the initial one was 2005. This was a follow-up in 2019 when I was in residency. But they showed the same thing, that this 0.5 is predictive of bypass patency. Now, if you have 0.5 or less, it's not saying that you won't have a patent bypass, but it's a 50-50 chance at that point. All right, so now to touch on some of the research that I did when I was a fellow. And that is this question of why bypasses fail. So this equation is something that all of you are most likely familiar with at this point, but it talks about flow. And this equation allows you to see the relationship of flow to the radius to the fourth power, length, viscosity, and this pressure gradient. And when you look at this equation, you do think that, well, of course, radius is going to have the highest influence because it's raised to the fourth power. Of course, it's going to be the most important factor. However, in situ, the pressure gradient tends to be also if equally important, if not sometimes more, because if you have no gradient, there's going to be no flow. So you have to have supply and demand there. This rationale explains why the STA, even though it is a relatively small vessel, can work as a conduit in many bypasses. And then also why the cut flow index does predict patency so well. That's because it speaks to the supply and demand interaction. So one of the first questions I was looking at was whether disease etiology mattered. And so I looked at atherosclerotic disease versus moyamoya. And that's because in our M&Ms and our neurovascular conference, we would talk about when bypasses failed. And just anecdotally, it seems to us that patients that had a lot of cardiovascular risk factors, atherosclerotic disease, were the ones that would fail more often. And so we wanted to look at that and took it to our database. But what we found is that that just is not true, actually. So at last follow-up, and follow-up on average was about 2 to 3 years for patients. The rates of occlusion did not matter, or they did not differ, I should say, between the different groups. It's about 25% for both. And I should mention that that is higher than the literature. The literature will say patency rates of like up to 90+%. Our thought is that our way of deciding if something is patent or not is a little bit different, and that is specifically through our quantitative MRA. We would actually, if something had flow through it, that is what we called patent, versus an angiogram where we actually would see it. And that's indifferent, or that is different from like a CTA or an MRA without the quantification, where you actually just see if the STA is present and connected, which doesn't always indicate that it's patent. So, but anyway, so looking at these two diseases, it did not actually change. Now, of the bypasses that occluded, atherosclerotic disease did have more occlusions within 1 week, but that was actually not significant. And then also looking at patients with atherosclerotic disease, the ones that did occlude tended to be more symptomatic, and they were the one, and that was significant, that they had stroke or TIA once they occluded. And that there was a higher rate of stroke in those patients with ICAD at last follow-up, which those are not necessarily surprising findings, but that's what our data told us. But of all of that, CFI still remained the best predictor of occlusion, and those same rates of about 0.5, actually a little bit higher threshold in this, versus 0.9 are going to be what's associated with patency versus occlusion. So then after that study, and it didn't really show a lot in terms of difference, I still wanted to look at specific cardiovascular risk factors. And this is something I was doing recently over the last part of the fellowship year. And what I did was I looked at all of the cardiovascular risk factors. These are some baseline information about the patients as well. And I looked at whether things were patent or not patent. And what I found was actually, there were not many differences in these cardiovascular risk factors between patent and not patent bypasses. And then looking at the flow differences, the only thing that actually stood out for looking at patent and not patent bypasses was patient sex and the cut flow index, which I thought was very interesting. So then I looked into that a little bit further to see, well, what are the differences between men and women? This actually has not been studied previously in cerebral bypass. It's studied in other diseases, other vascular diseases, including CABG, including CEA. And there is a very clear direction in the literature for those diseases that women actually have worse outcomes compared to men in both of those. So what I looked at here was men versus women. And what I found was that men tended to have more cardiovascular risk factors than women, which was interesting. And despite having more cardiovascular risk factors, women still had higher occlusion rates, which was, and then if you see here, I did include information about bypass type and anastomosis sites. So on a second analysis that I don't have the table displayed for, I did only look at STA-MCA bypasses as well. But this table looked almost identical between men and women. Men just had more cardiovascular risk factors. Women had less. Women, in fact, used more aspirin and Plavix compared to men when I looked at the STA-MCA bypasses only. So then doing a two-way ANOVA to try and parse this out a little bit more, looking at men and women versus patent and not patent bypasses and the cut flow index. Essentially, there is a difference between patency. So yes and no, like the cut flow index is different. However, there is no interacting effect there. It was almost significant, but not quite. So those lines are not statistically different from one another. I did, and it's actually not shown here, but I did look at that, and I don't have the picture there, but it is interesting finding. So basically, the diameter of the vessel, on average, was not significantly different, but there was a difference between men and women, such that smaller arteries for men were less likely to be patent than larger arteries. But in women, that difference was not there. It was basically the same size for patent and not patent. Exactly, yeah. So the last slide, I think it's the last slide, is about the my follow-up analysis here was the propensity score matching, where I included all the cardiovascular risk factors, and I wanted to propensity score match them and look at the odds ratios. So before adjusting for the cut flow index, women did show a 2.5 higher odds of occlusion than men. But when adjusting for CFI, that effect was not an independent predictor anymore. So I still think that ultimately there's something to be said here. I think that this speaks to the fact that these studies that have been done, the randomized controlled trials, should maybe go back to the data and see if there was in fact any difference between men and women. The MCOS trial did at least say that they did not have a lot of women in their study. They did address the fact that they should have done better with recruitment of women. But that was really the only mention there. No specific analysis is looking at the effects of patient sex, which I think is interesting, especially in the context of other vascular diseases. And I think that that is it. But thank you so much. I'm happy to answer any questions that you might have.
Because if we're smart about it, we're going to be applying these tumors. We should be applying this to hydrocephalus. How will we perfuse those conditions? Mm-hmm. But
so one thing that I didn't mention in these pictures, because I didn't really focus on the flow replacement bypass, is whenever you're using the microflow probe for that situation, what we would do is measure the flow through the ICA or the MCA, whatever branch we knew we'd have to occlude. We'd measure it before doing the bypass to actually see if the amount of flow going through that vessel would be adequately addressed by whatever conduit we were considering. So we would do that, and so that actually helped us figure out and game time decision making about what we thought would be the most effective graft. Right, I've stunned you into silence. Thank you so much.